Hello, everyone, and welcome. My name is Megan Mooney. I'm the Director of Engagement and Partnerships at IHME, and I'll be your facilitator today. I'd like to extend a very warm welcome to everyone for joining. It's a cold, dark morning in Seattle. Hope everyone is doing well wherever you're calling in from. Thank you for joining us today for our session, GBD 2023 Critical Findings and Their Global Significance with Dr. Christopher Murray. This is the first session in our GBD 2023 in Focus series, in which we'll provide an overview of the GBD 2023 results, followed by a more in-depth look at each of the three capstone publications for this round of the GBD. On the screen, you've got information about upcoming events. We have a robust series of events planned for collaborators over the next several weeks. And if you haven't registered yet and find any of these to be of interest, you can log into the collaborator portal, and there you'll find all the information about how to register and attend. As this is an exclusive session for GBD collaborators, it's really essential to begin by recognizing the contributions that each of you have made to the GBD and our collective achievement in publishing this latest update. Thank you so much. We hope to continue working with you into the future. As you all know, the GBD 2023 is the latest update to the GBD study, which is a systematic and scientific approach to understanding health loss due to a wide range of injuries, illnesses, and risk factors for all ages, by sex, for all locations in the world from 1990 to 2023. At its very core, it can help us serve policymakers in understanding where and how their country's health systems are working and where there are challenges. Today, we have the distinct pleasure of having Dr. Christopher Murray, the co-creator of the GBD and its principal investigator, here as our presenter. If you'll allow me, I'll tell you just a little bit about him, and then I'll share a little bit about today's proceedings and hand over the floor for his presentation. So Chris Murray is the founding director of IHME, which is an independent research institution at the University of Washington. He leads the Global Burden of Diseases, Injuries, and Risk Factors study, and he developed the GBD framework. He's a professor and chair of health metric sciences at the university. He has a Bachelor's of Arts and Sciences degree from Harvard University, a DPhil in International Health Economics from Oxford University, and a medical degree from Harvard Medical School. His career has focused on improving population health worldwide through better evidence, and his work has led to the development of a range of new methods and empirical studies to strengthen health measurement, analyze the performance of healthcare systems, understand the drivers of health, and produce forecasts of the future state of health in the world. Before Dr. Murray begins his presentation, we'll briefly review our agenda and some housekeeping, and then I'll hand over the floor. So in today's session, we will spend approximately 30 minutes looking at the critical findings across all three of the capstone papers, which came out in The Lancet last week. And then we will have about 20 minutes for question and answer. And we really encourage each of you to use the Q&A feature. Here's some information on the screen about how to do that. Use the Q&A feature in Zoom to ask your questions. Out of necessity, all of the mics are muted. So if you would like to ask a question today, please do so using the Q&A feature. And if you would like to send us any questions that aren't answered today after the presentation is over, please feel free to send them to gbdsec@uw.edu. And lastly, the session is being recorded and will be circulated to the full collaborator network, and you can access it at any time. Okay, with that, I am going to turn the floor over to Dr. Murray.
Great, thank you, Megan. And it's a pleasure to be able to share this presentation on GBD 2023. I'm going to, let's make sure I've got my slides working. There we go. On the right is the cover of the issue of The Lancet that came out last week for the global burden of disease. And as Megan mentioned, we like to think of the GBD as emphasizing that it is a rules-based approach to evidence synthesis for global health. In the current iteration of the GBD, we have a time series, and it's important to remember that whenever we produce a new GBD, we recompute the entire time series so that we're always presenting a coherent view of trends and levels. We cover 375 diseases and injuries. Some diseases and injuries have multiple clinical sequelae that we track and evaluate. So think diabetes, you have diabetic retinopathy, you have diabetes itself, you have a range of other clinical outcomes. Some diseases have only one clinical outcome, let's say the acute infectious episode of a condition. The GBD covers 204 countries and territories, and we have subnational assessments for 20 countries and some others in process of being developed. In addition to a view of the world based on diseases and injuries, the GBD, since its inception, since GBD 1990, has also included counterfactual assessments of what is the burden attributable to different risk exposures. And we have, in the current iteration, 88 risk exposures. Now, on the GBD, we have many different metrics, and I'll come to that in a moment, as well as what's unique to the GBD, which is these rolled up metrics that we have developed for the first GBD and continue to this day. Now, the purpose of the traditional metrics is to provide a highly standardized, curated database that allows comparison across place and over time for disease, injury, incidence, and prevalence, for risk factor exposure, for death rates, for cause-specific death rates, for age-standardized death rates. So a big array of metrics that anybody who works in epidemiology or public health would be familiar with. But in addition, to reflect the health loss associated with different diseases, injuries, and risks, we also compute the summary metrics. So deaths are converted, in addition to reporting on deaths, to years of life lost. And that is the premise there is that a death at a younger age represents more loss of health than a death at, let's say, 95. Then we take the prevalence of all those clinical sequelae of all the diseases and injuries, and we take the public's view of severity of health loss associated with each of those states, multiply the two together, and we get years lived with disability. And then we add the two together to get one of our apex measures, which is disability adjusted life years. And they're, basically years of health lost. We take the exact same information and compute a positive measure of health, namely healthy life expectancy. So the matrix of information going into DALYs and the matrix of information going into HALE are the same. Now, as Megan said, you, the collaborators, are a critical, essential component of how the burden of disease is produced. And this is a map just showing that the collaboration is really truly global and has a predominance of participants from all regions of the world, and I think is an essential part of the strength of the GBD. I mentioned that we have subnational locations. For GBD 2023, what we're talking about today, the ones in green have been analyzed at the subnational level. And for GBD 2025, probably not 2024, because we'll skip ahead to GBD 2025 next year, we will add France, where we're working with Santé Publique, and with the Kingdom of Saudi Arabia, where we're working with their public health agency to produce subnational burden of disease in those locations. So what's interesting on the subnational front is that the development of subnational burden has driven a lot of innovative uses of the GBD, and we can talk a little bit about what those uses have become in a moment. Now, I'm going to try to emphasize in my presentation visuals, not from the papers, which you can read, but from one of the online tools called GBD Compare. I'm sure most, if not all of you have used it. And that way you can understand how to get the types of images that I'll use them for teaching, use them for writing papers, use them for policy briefs and other applications. So that's one critical tool, GBD Compare on the left. Another critical tool, particularly for those who are interested in the research or sort of deeper understanding of estimates for your locality or for a region or for wherever your interests take you, is the Global Health Data Exchange showed on the right. And the website for that is ghdx.healthdata.org. And it's an online catalog. And so all 317,000 data sources used in GBD23, the metadata for those data sources are there. And in some cases, you can get directions where we're allowed, or even download some of the data sets direct from the GHDX. Just so you understand what a data source is, the vital statistics for a country for a year would be considered one data source. A household survey would be one data source. So 317,000 sources is a lot of different sources, and some of the complexity of the GBD is, of course, trying to take advantage of all these different sources, align case definitions, assays, meaning, and then use them in a standardized statistical framework to come up with this very large set of curated information. Okay, so that's all I'm going to say on the background, and now I'm going to jump into some of the results and give you a flavor of what seems to me, sort of quite personally, interesting that comes out of GBD 2023. Let's start with life expectancy. It's focusing, of course, on the on death rates and premature mortality, and not yet looking at causes, but it's a good starting point. And this plot shows life expectancy by GBD superregions, on the left for females, on the right for males, back to 1990. As those of you are on this, are part of the collaboration, you know that our demographic analyses go back to 1950. So that's mortality and fertility and population. And then the full GBD goes from 1990 to 2023. And this shows forecasts in addition, which are not in the papers published, but I think it's useful framing of life expectancy as well. And we've lived through a period of improvement in the long-term view in life expectancy in all regions, and some narrowing of the gap between regions. And we've recovered mostly from the drop in life expectancy from COVID. And so that's an important aspect of the findings in the first paper on demography. And it has taken to 2023 to mostly recover. There are some places that are just getting back to 2019 levels. And if you look historically, life expectancy was on an upward trend. So we haven't fully achieved sort of back to where we would have been. Now, what's very nice in GBD Compare is you can go in and look at these change in life expectancy plots. It's one of the options on the bottom left of the icons in the tool. And this is showing change in life expectancy for 1990 to 2023, grouping countries not by geography, but by World Bank income class. So at the top, we have World Bank low income, then lower middle income, then upper middle income, and then high income. The solid vertical line is the life expectancy in 1990. The dashed vertical line is the life expectancy in 2023. And then using a thing called Dasgupta decomposition, we are able to assign the change in life expectancy to different causes. Now, for those of you interested, when you take a measure like life expectancy, which is the function of all the different age-specific death rates, and try to decompose it into the causes contributing to that. That's a complex procedure. It's a non-linear procedure. But nevertheless, it gives you one view of what's contributing to these changes in life expectancy. And when you look at this plot, there's a lot of rather interesting things to see, which is we see bigger improvements in low income and progressively smaller as you go to high income. So there's catch up in absolute terms. Most of the improvement in low income and lower middle income countries are in the red colors, which are going to be, in GBD speak, the first grouping of causes. That's those causes more associated with poverty. So that's communicable, maternal, neonatal, and nutritional causes. And you can see the contributions from HIV/AIDS, from TB and respiratory infections, enteric infections, etc. But when we go to upper middle income and high income countries, the improvement in life expectancy is driven almost exclusively, particularly in high income countries, by reductions in non-communicable diseases, particularly cardiovascular, and to some extent cancers, the very dark blue shading. And changes in injuries are a smaller contribution in each region. And unfortunately, there's a little light blue segment to the left of the vertical line, the solid line, which says that that cause actually lowered life expectancy, but other causes reduced enough to compensate. And that reduction is substance abuse, and then in some places also diabetes and chronic kidney disease. Now we can flip views on this change in life expectancy and go back to the geographically based regions we use in the GBD. And here you can see a bigger range than across low income to high income, as you would expect. You can see that the lowest life expectancy in 2023 across GBD regions for both sexes combined on this plot. Let me just make sure I am giving you the correct information. This is actually for males. The next will be females. The lowest life expectancy is in Central Sub-Saharan Africa, with a life expectancy in 2023 of about 60 for that region. And the highest has become Australasia for men, beating out high-income Asia-Pacific, interestingly, around about just below 82 for men. And you can see the changes in life expectancy over the period of the 33 years shown on this plot, again, reflect this predominant reduction in communicable maternal and neonatal causes in low-resourced regions, particularly in Sub-Saharan Africa, and then the contribution of reductions in cardiovascular disease. But you can more prominently see causes that got worse over that interval: HIV in Southern Sub-Saharan Africa in the dark red, and then you see quite a little light green color, and that is actually increases in suicide in Eastern Europe that point out. And in Central Latin America, high-income North America, you can see the light blue, which is drug use disorders, making a negative contribution to change. So there's a lot of information here on both the distribution of life expectancy across location and changes and the causes that are driving that. When we switch to females, notice that the x-axis is going to shift. And now we have life expectancy spanning, and the worst off region is again Central Sub-Saharan Africa, the dashed line, vertically, now at about 64, going up to as high as 87 in high-income Asia-Pacific. So at the high end, it's interesting that Australasia has now doing better than the Japans and the Koreas and Singapores, et cetera, the high-income Asia-Pacific for males. Now you can see really marked improvement in East Asia, particularly for females, shown here, with that, which is dominated, of course, by China. Really extraordinary gains, but also extraordinary gains in South Asia. So that South Asia is now ahead of, for example, Oceania, where it was well behind it before. It is ahead of all the African subregions. And you see that it's not a simple static epidemiological transition where every country is sort of progressing through. No, there's very different rates across regions, and we'll see in a moment that is even more true across countries. Now here's a map from GBD Compare of life expectancy at birth for both sexes now combined. And when you take this both sexes view, you get Central African Republic at the lowest end at 55. And at the highest end for both sexes combined, we have Singapore at 85. So across countries in 2023, we have a 30-year span of life expectancy. That is an enormous span still in 2023, even if the range across countries has narrowed a little somewhat over the past 3 decades, and certainly narrowed over the past 70 years that's included in the demographic analyses in the GBD. Notice the concentration of life expectancies below 60 in a number of countries in the Sahel, in Central Africa, and then we also see that's true in Lesotho and Swaziland. Okay, now, one of my favorite views in GBD Compare is the tree map view, because it's a good macro way of understanding the epidemiological transition and sort of where we are in the contribution of different causes. So as a reminder, this is showing global deaths for both sexes in 1990. And the boxes are proportionate to the share, the size of the boxes are proportionate to the share of those global deaths in 1990. And they're colored by the big 3 groups in the GBD. So you have non-communicable diseases in blue, communicable maternal, neonatal, and nutritional in the red-orange colors. And then you have the injuries in green. And the shading is a measure of the time trend. So things that are going up, in this case, in the number of deaths, are more darkly shaded. So falls and Alzheimer's as examples, or HIV. And things that are going down are more lightly shaded. And generally, for deaths, you see in 1990 that the majority, just over the majority, or maybe about 55% of deaths were from non-communicable diseases. The communicable maternal and neonatal causes were still very large, with prominent roles of lower respiratory infection and diarrhea, TB, malaria, neonatal causes. And amongst the NCDs in blue, you have stroke and IHD as the really large ones, and COPD. In the injuries, you have drowning, self-harm, road injury, violence, and falls that tend to dominate. Now go forward to 2023, and the fraction of deaths now has greatly expanded, due to non-communicable diseases, has greatly expanded. The fraction due to the communicable maternal and neonatal causes has shrunk. COVID has now emerged, not reemerged. And you can see that falls, self-harm, and road injury are even more predominant amongst the injuries. Now, the thing about deaths that we don't really like as a measure is that they treat a death at 95 as the same as the death at age 20 or age 5. So that doesn't seem right, which is why we like years of life lost. And then add on the non-fatal part, we like DALYs, which we'll shift to in a moment. The other thing about this shift in deaths is it's very, very sensitive to the age of the population. So as the world's population, mostly outside of sub-Saharan Africa, ages quite profoundly, we expect a shift. Even if all the age-specific rates were constant, we expect a big shift towards the NCDs, which is what we see. But there's also things happening in the background to the age-specific rates. They're going down for many of the infectious diseases, and they are going down or even up in some cases, like diabetes, for some of the NCDs. All right, now here's DALYs. The big difference on DALYs, as a reminder, is that we are doing 2 things. We're taking those deaths and saying, if you died at a younger age, that's more years of life lost. And we're adding in the non-fatal part. So back in 1990, you can see that that means that the communicable maternal and neonatal causes were larger as a share than NCDs because they tend to kill people at younger ages. And that's why the orange boxes are so much larger. Same is true for injuries. So NCDs go from being the majority of deaths in 1990 to not being the majority of deaths below that. And you can see once we shift to DALYs, things creeping in like mental health disorders, depression and anxiety. You can see musculoskeletal disorders like back pain and neck pain showing up on the list, and congenital disorders, which a number of them lead to disability, showing up as a more prominent cause. Now go forward to 2023. We see in DALY space the epidemiological transition at the global level. Big shift towards NCDs, contraction of the components due to the communicable maternal and neonatal causes. But we still have a large contribution from stroke, IHD, much bigger contribution now due to depression and anxiety in terms of the share, and diabetes and chronic kidney disease seem larger. HIV is larger than it was in 1990. Of course, the peak of HIV globally was 2005, and the rollout of antiretrovirals means that if we looked at these boxes for 2005, HIV would have been larger. It's now shrinking. Nevertheless, you can see that at the global scale, it's really quite a complex set of causes that deserve our attention. Now, in GBD Compare, you can go in and just toggle to various geographies. I've toggled to World Bank low income here. And just to emphasize that while at the global level, we see this huge epidemiological transition, the world's population and very large populations in China and India have undergone profound epidemiological shifts. But if we go to low-income countries, we still see, as we did at the global level in 1990, the predominance of the communicable maternal and neonatal causes. And I think it's very important when you're looking, and you can play around in this in the various tools, that when you take into account age structure in low-income countries where the population is still very young, that has a big effect on the burden that you'll see. And if you toggle to like age standardized rates and remove the effect of age structure, you do make the NCD transition look more advanced in low income settings than if you take the numbers as they actually come. Now, to sort of emphasize this difference in views from a very traditional counting deaths view on the left, top 10 causes of death type lists that some countries make, I've made this plot by taking the rank order option in GBD Compare for deaths on the far left at the global level, for years of life lost in the middle, for again at the global level, and then for DALYs on the right, just to show how taking into account the age of death, going from deaths to OLLs changes the rank orders quite a lot, and then taking into account the non-fatal it changes them again quite a lot. So ischemic heart disease is number one, regardless. But you can see, for example, neonatal disorders is only 10th in terms of the number of deaths, third in terms of years of life lost, second in terms of DALYs, because it also contributes a lot of disability. Take something like low back pain. It's not on the list. It doesn't cause death on the far left. It's not on the YLL list, but it shoots up to number 5 on the far right. Take diabetes, where as a cause of death, it's number 6, drops to number 10 in years of life lost, but because of all of the clinical sequelae associated with diabetes, goes back up to number 6 on the right. If you take falls is 17th as a cause of death. It's not even on the top 20 list for YLLs, but because there's quite a lot of broken hips, disability associated with falls, it goes up to number 10 on the DALY list. And you can do this type of analysis across the spectrum here to better understand how the different views change your perception of what's a leading cause of burden. And one of the reasons in GBD Compare we make all of these different views possible is that different users and different audiences care about different things. And it's all there for you to play with and develop insights, and then, of course, also to write papers about. Now, I'm going to go on to risk factors. Just to remind everybody that starting about 3 years ago, we've been transitioning in the risk factor assessment to using the burden of proof methods to establish the risk curves that relate exposure to particular outcomes. Now, remember, on the GBD, the risk factor side of things uses a counterfactual notion of causality, where we try to answer the question, what would happen to deaths, Ls, Ds, Dallies, if the exposure to a risk was set to the theoretical minimum risk exposure level? If nobody had smoked, for example, or everybody had a BMI, between 22 and 24, things like that. Now, to put that on the strongest possible footing, we introduce this method in Nature Medicine called the burden of proof. We've subsequently, the collaboration has published some 15 burden of proof papers, which then give you a star rating for the strength of the relationship. There's a tool online you can go and interrogate what are each of the component studies that go into an assessment of the burden of a risk function. And here's a 5-star relationship, meaning that we don't think that the relationship between high blood pressure, high systolic blood pressure, and ischemic heart disease is going to change if new studies come along. And you can hover over each of those points and know exactly which study that's coming from. And it provides a very standardized way to think about what is the strength of the evidence for a relationship. Okay, on to some risk factor results. Now, just as in the GBD disease and injury view, where there's a causal hierarchy, group 1, 2, and 3, the big groups, communicable maternal neonatal, NCDs, injuries, you can go down a layer to level 2 and see big clusters like cancers or cardiovascular disease, and then go down another layer and down to the 4th layer. In the risk factors, we have also created a risk hierarchy, as you know. So you can look at risk factors in different views. This is a somewhat aggregated view, so we're putting all the causes of malnutrition, maternal and child, together. We're putting both causes of air pollution, indoor and outdoor, together. We're putting all the uses of tobacco, so not just smoking, together. We're putting all 15 components of diet together. So that is the view we're looking at, and we're looking globally. The x-axis is the percent of burden related to these risks. And at the top, despite all the progress the world has made, malnutrition in this view is still the #1 risk factor, which is a sobering reflection that there are such large inequalities still in the world. Next in this aggregate view is high blood pressure, then air pollution and tobacco about the same, or slightly air pollution slightly ahead of tobacco. Then diet is a large cluster, high blood sugar, and overweight and obesity, high body mass index, and on down the list. Now, people, when you make presentations, often think globally that water and sanitation is the #1 problem still in the world. And at the global level, it's quite far down the list. It's still important. It's 2% of burden, but it is far below these other risks, whether malnutrition or air pollution, which often affect the poor, and then the big NCD risks that we're seeing there. Now, I can go down a notch and look at much more detailed risks, right? So now we're not grouping the risk factors, and we're ordering the risks at a more detailed level. And here, the #1 risk is high blood pressure, and then high blood sugar and smoking. And then we get low birth weight, overweight and obesity, ambient air pollution, household air pollution, short gestation. And I want to note as we go down this list that there's a long list of risk factors that make important contributions. And it's part of, the complexity that we see when we look at burden of disease around the world. Just like disease and injuries, risk factors vary a lot by locality. So if we go to low income settings, this is World Bank low income, suddenly you see a range of risk factors at the top that are the risks characterized by poverty. And so we have low birth weight, household air pollution, short gestation, child underweight, child wasting, unsafe water. Now you finally see high blood pressure creeping in, child stunting, unsafe sex, unsafe sanitation, hand washing. And so the cluster of risks representing the young age structure, higher levels of poverty, still exposure to these risks that have mostly been addressed in middle income and high income countries, you get this very different pattern that you can see there. Okay, now I'm going to pull out from the results a few high level findings that I think warrant attention. And these are the findings, by the way, that we emphasized at the World Health Summit when we launched the GBD in Berlin last week. So first, on the left-hand panel is showing the probability of birth to age 20. Now, we're all used to talking about under 5 mortality, which is the probability of death from birth to age 5, but there's enough cumulative risk of death between 5 and 20 that I've put them together here to show death in children and adolescents on the left for low income up to high income countries. And you can see there's progress everywhere, which is great, from 1990 to 2023. But there's still a 10-fold variation from low income to high income in that probability of death. So it's still very high when you look at low income countries, the blue dots on the left. And if you look for 2023 on the map on the right, where are these probabilities of child and adolescent death highest? Well, it's very predominantly in the Sahel, or if you want to think of it, the Sahel extending through to Somalia. So that latitude in sub-Saharan Africa. And it's a pretty marked phenomenon, and we'll see in a moment that there's good reason to think that that's increasingly where the greatest inequalities at the global scale are now and will continue to be for a number of decades. Why? Well, if we look at the total fertility rate from the GBD, the very same places with the highest child death rates are also the places where the TFR is still over 6. So we've seen quite marked declines in fertility everywhere in the world, including in East and Southern Africa. Look at a place like South Africa where fertility is below replacement, or Kenya where it's between 2 and 3. But in Niger, in Mali, in Chad, in Central African Republic, we have TFRs over 6 as we do in Somalia. And so the combination of high poverty rates, high child mortality, increasing in the future share of the world's population will be in these challenging environments for children and adolescents and also for adults. Other huge phenomenon that's going on is the global transition towards NCDs. I showed it with the tree map plots at the global level, but here's a line graph on the left, one of the options that you can look at in GBD Compare, showing the trend in the share of burden due to NCDs going up everywhere, but in absolute percentage points, I think the most profound increase is in lower middle income countries, where you've gone from 25% in 1990 to 57% in 2023. And that's actually a really profound shift in a pretty short period of time, three and a bit decades. Meaning that health systems and health leaders in those countries, in the lower middle income countries, need to be changing their emphasis in time with what's happening in the population. And that's very hard to do. If you think that most governments and providers are really still focused on what they were trained to look at, and often that's maternal and child health. And so there's a disconnect often between the epidemiological transition and what's happening in those countries. Another big shift that's occurring, accelerated by the COVID epidemic, but being driven by many factors, aging part of it, but increasing rates of anxiety and depression, is the rise of mental disorders as a share of burden, happening everywhere, including low-income countries. And as you can see on the right panel, the big contributors to mental health burden are actually, an important contribution from schizophrenia, but the big action is around depression and generalized anxiety disorders, the middle red and the sort of orange color on the right. Now, we are spending increasing amounts of time in the GBD looking at the impact of climate. And here's just focusing in on deaths now, not DALYs, due to high temperature. I'm using deaths because most of the other literature on temperature talks about deaths, so just to locate it in that space. And it's the number of deaths on the left panel going up. At the global level, it's gone from about 250,000 heat-related deaths to about 550,000 in 2023, so a steady rise. And of course, we expect that to continue rising in the future. And showing on the right panel how deaths due to high temperature affect young and old. In the young, it's respiratory infections. In the older age groups, it's cardiovascular diseases, it's diabetes and chronic kidney disease in purple. And then in the middle age groups, the younger adults, it's injuries. It's both self-harm, road traffic injuries, and violence. No global assessment would be complete without emphasizing the enormous increase in overweight and obesity. If you think of the top risks we were talking about, things like high blood pressure, air pollution, tobacco, the only top risk that is steadily going up is overweight and obesity. And so that has a special prominence in our view because it's a major top 5 risk for DALYs, and it is steadily going up in all regions. There's no case that we can find in the data where overweight and obesity is going down. And this is the percent of DALYs, the PAF on the left, going up steadily in all places. Another one to emphasize is that in GBD 2023, we substantially revised our assessment of the relative risk of lead exposure on cardiovascular disease due to new studies that were published, as well as validation studies that we conducted using the NHANES cohort data. And that led to a much larger relative risk for cardiovascular disease and makes lead, when you look at detailed risks, the 10th leading risk factor in the world. Another big change due to the burden of proof assessments was in the risk factor assessments that deserves attention is the expansion of the number of risks for which there is convincing evidence, according to burden of proof, of the links between sexual violence against children and a much larger set of causes than we have previously estimated, shown here. So the effects of sexual violence against children when those children become adults is much more, a much broader set of causes, not just mental health causes that are linked as well. And let me end with the point that's not yet published, but it's part of as you know, the GBD approach, which is having this curated standardized database, which is the GBD, having a time series, allows us to use the data to look at aspects of how health systems function and perform. And here's one of the measures that you'll be familiar with. We use it extensively in the GBD, is the measure of healthcare access and quality, which is built up from the intellectual tradition of avoidable mortality that started in the 1970s. McKee and Nolte reinvigorated that tradition, and then we took those ideas a number of years back and built it into the GBD. And here's Healthcare Access and Quality in 2023, which basically uses risk-adjusted outcomes to give a window on how well a health system is delivering interventions to make a difference to outcomes. Now, we also can take the results from the GBD, and this was published in August in Lancet Global Health, and calculate a method that is called stochastic frontier analysis. This is Joe Dielman and his team. Amy Latsuka led this paper and came up with an assessment of how far countries are in years of hail from the best level of hail observed, adjusting for risk factors outside the control of the health system for their level of spend. And when you take that conditioning on the level of total health expenditure per capita, you get interesting insights. Some countries in that West Africa who spend very little, are very poor, like Niger, are pretty close to the best you can achieve at that level of spending, and also that level of socio-demographic index, whereas a country like the US is really quite far from there. So expect more, I think, in the coming months and years as we increasingly try to use the GBD as a platform for understanding how health systems are performing, and are they doing certain functions better than other functions. So we're shift over to Q&A, and I'll let Megan be the curator of the Q&A session.
Thank you so much, Dr. Murray, for that really tour de force of the key findings for GBD 2023. We have close to 300 people on the line and a lot of questions coming in, so please feel free to add your questions to the Q&A button at the bottom of your screen. To start off, we have a question from Dr. Adamu, who asks, what new methodological improvements were introduced in GBD 2023? And how do they enhance the accuracy of disease burden estimates compared to previous iterations of the GBD?
Great question. So the big change, and we'll see more of it in GBD 2025, has been the math sciences and computational algorithms team at IHME, led by Sasha Aravkin and Peng Zhang, have been developing over a number of years a modeling approach called OneMod, and has a number, it's a Bayesian modeling approach, has a number of attributes that are very attractive, and we rolled out using OneMod for all-cause mortality. The reason that this is really exciting is that historically in the literature on all-cause mortality, we have used, as everybody has, a method called model life tables, which, if you want to think about what a model life table is, it goes back to Cole and Domain in the 1960s, and it's basically a encapsulated view of the correlation structure of age-specific death rates. That if the death rate in 45 to 49 is something, then you would expect the death rate in 50 to 54 to be highly correlated. But there are different families of model life tables. There's different methods. I have developed a number of these in the past 3 decades. Other researchers have. The UN has a system. And the problem with these methods is they're sort of out of sync with modern, statistical techniques, where you shouldn't have to impose that. The data should tell us about the correlation of the age structure. And that's what OneMod allows us to do. So we've been able to get rid of entirely the model life table system approach and simply apply a Bayesian statistical algorithm to estimate all-cause mortality. That will roll out for cause-specific mortality next GBD round and replace coding. And we are carefully demonstrating that in-sample and out-of-sample predictive validity using this new approach is better than previous approaches. And so far we've done it for all cause. It's in GBD 2023. So that's a big factor. There's been a number of additional burden of proof studies that have been introduced. So that's not a new method, but the application of the burden of proof approach. I talked about sexual violence against children as one example, but that has happened across a number of outcomes. that's, and then for some causes, a very small set in GBD 2023, we have begun the transition from DISMOD MR to the new approach, which is DISMOD AT, age time, to do the non-fatal modeling. And we hope for GBD 2025 that all or nearly all diseases will have transitioned to the new tool. And what's nice about DISMOD AT, again, we can show this in sample and out of sample skill or predictive validity. We can see that it's a better modeling tool and much better able to pick up and infer trends and incidents, even if we only see prevalence data over time. So those are some of the big changes. I'm sure there are others that I have not touched on, but yeah.
Thank you. We also have a handful of questions about future directions in the GBD. So I'll ask a few of them and then invite Dr. Murray to expand on how he views future directions. First, we have, let's see, we're now getting a lot of questions in the chat. From an academic research perspective, what thematic or methodological gaps identified in GBD 2023 should be prioritized for collaborative investigation in the next research cycle? And then there's a few specific questions that I'll add on there. Do you plan to add war and conflict as risk factors? And then the individual asking the question distinguishes between state-based conflict, non-state conflict, and one-sided violence. We also have a question about, let's see, a few other specific suggestions. What are the plans for updating the severity scores of various diseases over time? And do you plan to include and share data on the financial burden of different conditions globally?
Okay, those are probably too many for me to keep in my head.
Okay.
Let's start with the question on war and conflict. Obviously, war and conflict's there as a cause, a categorical cause, and related to the GBD, but an extension of it. There is an ongoing effort for the Lancet Commission on 21st Century Global Threats to Health, which I co-chair with Natalia Kano, who until very recently was the head of UNFPA. For that work, we have been looking at long-range forecasting of many threats, including war and conflict, conventional and nuclear, and also as part of that work undertaken actually by a group at Harvard that we have been looking at trying to capture the indirect effects of conflict, which is perhaps not quite all the way down the chain of thinking about war and conflict as a risk factor and taking into account pathways like destruction of health infrastructure, but it starts to get close to it empirically. So that's one development. And there'll be a paper that'll go off for peer review on that global assessment, going off for peer review quite soon, and hopefully we'll see it in the literature next year. Second question, I think, was on severity distributions. Is that right, Megan?
Yeah, plans. The individual asks, I guess the severity score of diseases may change over time. What are the plans for updating them?
So we have a very ambitious plan, which we'll see if we can implement for GB 2025, to capture the dependent comorbidity, because currently we really only capture independent comorbidity, that is not capturing the empirical correlation, let's say, between drug use disorders and mental health disorders or diabetes and ischemic heart disease. We have not in the past captured that because it's been methodologically quite tricky. The math sciences program has figured out a quite elegant solution to that. So we believe, capture that. Then that raises the question about how we can, in overhauling the whole approach, more directly where the data are available, capture regional or location-specific differences in severity distributions. So I think given that overhaul on the GBD, that's a really interesting area of work. So, both what is in a particular place, what is what's called lift in the literature, which is how more commonly or less commonly than expected do you see various combinations of sequela, and then can we feed directly in the severity distributions from different locations? So I think we'll see both the capability to use that information is now going to be enhanced, but just lots of interest in that. And there's a lot of interest from people who use GBD in government, particularly as populations age, in a deeper and better understanding of those severity distributions and comorbidities, which I think we want to be responsive to as the methods unfold.
We have a great question here about the need to prioritize actions now. And given the current geopolitical situation, what would be the most important actions for regions like the Sahel and other low-income countries where you highlighted inequalities in progress?
If you look at a place like the Sahel, you can come at what's there in a very disease or risk specific view. The Sahel also, by the way, which I didn't emphasize enough in the presentation, will also be the place where rising heat from climate change will probably be the most severe. So you could come at it at a disease specific or risk specific way. Child malnutrition is still a really big risk there. So interventions around that. Or you can step back and say, look, the strategy that, at least from the data that we see, could have the biggest midterm impact is speeding up educational attainment. The levels of educational attainment are still very low. There are these incredible health benefits for children and adults from education. There are contributions to economic growth from education. There will, slow down population growth, which will make it easier for those governments to deliver essential services. Many factors would push you towards the view that advancing educational attainment in the Sahel should be a very important priority, along with trying to address the usual key diseases and risks that showed up at that top of the list there around malnutrition, water and sanitation, et cetera.
We're almost out of time, so I have maybe three more questions I hope you can get through. First, in this presentation, we see a striking shift towards non-communicable diseases in middle-income countries. Can you elaborate on how the GBD 2023 findings inform priorities for health systems that are still structured mainly around infectious disease control?
Look, I think it is one of the key messages here is the shift and speed of the shift, and the need for ministries of health and other health system leaders to take that shift on board and start thinking about programming for those new diseases, and to think about interventions, whether policy or program interventions, along the big key risks like high blood pressure. Many countries, both high income, middle income, lower middle income, don't have a national program on tackling blood pressure, and yet it's often their number one risk, as an example. So there are factors on the risk factor front that are very attractive, and then there's training the workforce, designing the health system to deliver the interventions that we know work around NCDs that predominate in a particular place. So if you think ahead, the increasing burden of, let's say, chronic kidney disease, diabetes, ischemic heart disease, and stroke, those require a different set of providers than perhaps a focus that you might have on maternity care or child health. So there's ramifications all the way through to long range planning around human resources and you know the types of interventions as well as the sort of risk factors you want to prioritize.
There's so many more questions in the chat, but at this point we are out of time. I want to thank everyone so much for joining us this morning and for sending your questions. We will endeavor to answer those that we didn't get to and send answers out to attendees. And in addition, please feel free to write to us at GBDSec if you have a specific suggestion, feedback, or thoughts on the presentation today and on the GBD 2023 overall. We could not do it without you, so we very much want to thank everyone on the line for joining us today and for being a really important part of making the GBD possible. Thank you so much to our presenter, Dr. Murray, for his time today, and we will be sending around the recording shortly. I hope everyone has a fantastic day. Take care.